Hello, my name is Oriana Lowe. I am a pediatric dentist practicing in Los Angeles, California, and I am presenting a lecture on ankylosis and ectopic eruption with treatment options. So I'd like to begin this lecture by going over the goals of today's session, and that is we would like to discuss possible causes of ankylosis, discuss ways to diagnose ankylosed teeth, discuss various treatment options, review ankylosis of primary molars with absence of permanent successors, review ankylosed permanent teeth, management of trauma, review disturbances of ectopic eruption and eruption guidance, and finally, we will be reviewing treatment options for ankylosed and ectopic eruption. The objectives of this lecture are to describe the ankylosis and ectopic eruption process, to know the clinical significance of ankylosis and ectopic eruption. The student should be able to describe the eruption process, review local and systemic factors that influence eruption. An accurate diagnosis of ankylosis and ectopic eruption should be formulated. Description of the prevalence of ankylosis and ectopic eruption will be known. And finally, the student should familiarize himself or herself with the treatment options for ankylosed and ectopically erupted teeth. So we'll begin with what is ankylosis? An ankylosed tooth is a tooth that has not erupted to the point of making contact with the opposing maxillary or mandibular tooth during mastication. This tooth can also be immobile. It doesn't move. It occurs in 3 to 4% of children. Maxillary arch is usually affected. Rarely does this occur in the mandible. There are local and systemic factors that influence eruption. These are the misconception that results from the fact that an ankylosed tooth is in a state of static retention, whereas the adjacent area, eruption and alveolar bone, continue to grow. Ankylosis should be considered an eruption in the rhythm of eruption. And observation suggests that a patient who has 1 or 2 ankylosed teeth is more prone to have other teeth become ankylosed. So here we have a picture of a mandibular primary molar that is ankylosed. And they, by the way, are the most often seen to be ankylosed teeth in the mouth. You see the premolar tooth, number 20, is inclined mesially, distally against the mesial root of the permanent molar. Causes of ankylosis is unknown. Several theories suggest a familial tendency that is non-sex linked. And based on the literature, there is no causal relationship between ankylosed precursors and congenitally absence of their successors. There is almost 1% of prevalence seen in African Americans and greater than 4% seen in the Caucasian population. Etiologic factors that may cause ankylosis include siblings with ectopic eruption, familial, shorter and smaller maxilla, larger mesial-distal width of the permanent first molar with increased mesial inclination. So let's talk a bit about the resorption process. The resorption process of a tooth root begins on the inner surface of the lingual surface of the root. The process is not continuous, but is interrupted by periods of inactivity or rest. Ankylosis of the primary molar to alveolar bone does not usually occur until after its root resorption begins. It may occasionally occur before the eruption and complete root formation of the primary tooth. Here's another photo of ankylosed teeth. In the first one, 914, you see that the ankylosed second primary molar has a large carious lesion on the occlusal surface, and it is infra-erupted. It's very hard to clean, and the child probably missed it, every time they were brushing their teeth on a daily basis. Here on 915, you see an ankylosed tooth that's deeply embedded in the bone. In order to remove this, you'd have to remove some of the bony framework that's impeding the eruption of that tooth, or you may want to leave that one alone. Picture A, you have a picture of a radiograph of an resorbing primary second molar with a non-resorbed distal root. This was seen on a radiograph on examination when the patient was in for a checkup, and the dentist decided to continue to observe. So a year later, in photo B, the tooth is still there. It never moved, causing impediment of the eruption of the premolar tooth, as you can see. So the choice here for treatment should have been removal or extraction of that second primary molar when it was first observed. So diagnosis of an ankylosed tooth are several. An ankylosed tooth is not mobile, even if you see advanced root resorption. It can be confirmed by tapping the suspected tooth and an adjacent normal tooth with a blunt instrument and comparing the sounds. Ankylosed teeth will have a solid sound, whereas a normal tooth will have a cushioned sound. Radiographically, the tooth may appear as a break in the continuity of the periodontal membrane. Ankylosed treatment options include early recognition and diagnosis. Surgical removal may be needed. Removal of the tooth and placing an implant. And 4, the dentist may continue to observe the ankylosed tooth unless there is significant caries or evidence of loss of arch length. Here's another picture of bilateral ankylosed teeth. And on the top, number 1 and 2, you do have the ankylosed second primary molars. And on 3 and 4, you see that the premolar teeth came in well after the second primary molars were removed. So let's go into a little literature of ankylosed primary molars with absence of the succedaneous permanent teeth. The presence of a permanent successor is important for normal exfoliation of a primary molar. One study showed that no ankylosed primary molar without permanent successor were found to exfoliate spontaneously, and slow root resorption was observed for most of the ankylosed teeth. So the bullet point number 1 means that if there is not a permanent successor to take the place of the primary molar, the roots will resorb very slowly, and there is a higher incidence of ankylosis because, as we know, the eruption process of the permanent teeth will enhance the resorption of the roots from the primary teeth, causing the primary teeth to loosen. But if the permanent tooth is missing and there is no permanent tooth bud, then this is going to be difficult. Ankylosis, in a patient where there is an abnormality associated with agenesis or ectopic eruption, early intervention is most likely required. When the successing teeth are missing, trying to establish functional occlusion using stainless steel crowns, overlays, or bonded composite resins on the affected primary molars is the treatment of choice. Ankylosis, also known as infra-occlusion, may occur prior to the emergence of the occlusal contact with the opposing arch. ankylosis is best described clinically as a submerged tooth, dull noise to percussion, and the primary mandibular molar is most often affected. And again, when you are examining a child's mouth and you see that one of the molars is below the average occlusion surface, then something's going on. You need to make sure you take an x-ray to see what's causing that tooth not to be aligned occlusally. Possible extrinsic factors that may cause ankylosis include trauma and localized infection, disturbed local metabolism, and tooth replantation. Characteristics of an ankylosed tooth includes immobility. The ankylosed tooth may have a solid sound when tapped with a blunt instrument compared to a normal tooth, which has a cushioned sound. Radiographically, the tooth may appear as a break in the membrane. And again, treatment of an ankylosed tooth, which is below the plane of occlusion, is best restored with a stainless steel crown, build it with bonded composite resin, or an amalgam buildup. Of course, we don't use amalgam much more, if at all, nowadays, but there are some instances where offices still use that as a treatment of choice. Now, again, the teeth that are most likely to be ankylosed are the primary canines, the primary lateral incisors, permanent mandibular molars, and permanent mandibular bicuspids. The resorption process of an ankylosed tooth begins on the inner surface of the teeth, of the roots. So here we have some pictures of treatment options. As we see here on A, the primary second molar has no succedaneous tooth below it. So you try to leave that tooth in as long as possible to hold the space. When that exfoliates, then a dental implant is probably the best treatment of choice. The next picture B with the stainless steel crown, the crown is placed for plane of occlusion. Otherwise, the maxillary tooth that occludes to it is going to be elongated or come supra-erupted. So you want to stop the super-eruption of the maxillary tooth by putting something to stop the bite or the forces from that tooth coming down. Possible treatment options, again, is surgical removal of the ankylosed tooth, early intervention, and tooth removal and placing an implant. The early intervention, you may have to consult an orthodontist or use your best judgment. Now, a bit about ankylosed permanent teeth. The etiology includes incomplete eruption of a permanent molar may be related to a small area of root ankylosis. Reaction observed after trauma to anterior, primary, or permanent teeth will cause permanent teeth to be ankylosed, and unerupted permanent teeth may become ankylosed by reformation of the enamel. Many times, an ankylosed permanent tooth may be caused by injury to the periodontal ligament and subsequent inflammation, which is associated with invasion by osteoclastic cells. The result is an irregularly resorbed areas on the peripheral root surface, and you will see a mechanical lock of fusion between the alveolar bone and root surface. So a technique that has been more popularly used when removing an ankylosed tooth is the luxation technique. I mention this because this is something that we can do in practice and that we have done in private practice without having to refer the patient to the oral surgeon. So it's a technique that effects a break in the bony ankylosis. It's a rocking technique that you would put your elevator in and you rock the tooth back and forth mesodistally buccolingually. You can also use a forceps to help you rock the tooth back and forth buccolingually, but I found that using an elevator worked best for me. And if it's not successful on that first visit to try to remove the tooth, you may want to get the patient back in several months to repeat the process. If you delay treatment, then it may result in a permanently ankylosed molar. It'll just fuse to the bone, and there's no consequence. So now we will speak about ectopic eruption. Let's differentiate between ectopic eruption and impaction. What is impaction? Impaction is when the tooth or teeth cannot erupt because something impedes it, not because of ectopic position. Ectopic eruption reflects the eruption of the tooth in an abnormal position. The most frequently found ectopically erupted teeth are: 1, the maxillary first permanent molars and the maxillary canines. The mandibular canine and mandibular second molar, and the maxillary lateral incentros. The maxillary lateral incisors. So when do you treat? Evidence shows that if you have a delay or of ectopic erupted teeth, you will cause some active eruption process through ankylosis. Eventually, a discrepancy between the position of the tooth and its adjacent will be obvious. The uninjured teeth will continue to erupt and may drift mesially with the loss of arch length. And finally, the removal of a permanent tooth that becomes ankylosed is often necessary, especially if the ankylosis occurs during early adolescence. So what is EE? What causes EE? And unique etiologic factor for ectopic eruption has not been reported, but some of the common reasons for EE are: 1, an abnormally large first permanent molar and second primary molar. And 2, a maxillary first permanent molar is the most commonly affected tooth. The mandibular first permanent molar is the most ankylosed. So remember that maxillary first permanent molar is the most commonly affected with ectopic eruption, and the mandibular first permanent molar is the most ankylosed. So here is a diagram of the second primary molar resorption. In grade 1, you see cementum and minimum dentin being affected. Grade 2, you have the permanent tooth coming in towards the second primary molar. Grade 3, you have severe movement that affects the distal root and has pulp exposure to the second primary molar. And grade 4 is very severe. It affects the mesial root. And how do you treat this? Many times you keep the second primary molar in place for space maintaining purposes. If the tooth becomes symptomatic, then you would extract the tooth, and hopefully you'll be able to place a molar erupting device to upright that molar. Treatment options: again, you can remove some of the soft tissue and bony covering that surrounds the occlusal of the crown of that molar, and pack it with a type of surgical cement, which will provide a pathway for the developing tooth. In cases with irreversible ectopic eruption against a permanent molar, interceptive treatment is warranted. Treatment options include uprighting the permanent molar, no treatment, and extraction of the deciduous molar is not an option. Why? But it could be an option because if the child has pain and you know that the permanent molar has no way to go, and it is possible to place a space-maintaining device, then you can extract that second deciduous molar. And here is just some examples of retained teeth. You see on that last picture F that the second primary molar, the distal root, is well resorbed, and the mesial root has not resorbed it well. So the best treatment for this is eventually attempting to remove that inadequately resorbed second primary molar to allow the premolar to erupt in place. So the eruption problems and eruption guidance. The benchmark of a tooth size, arch size discrepancy usually results from one, abnormal eruption patterns with a resultant ectopic displacement, asymmetry of alignment, which is crowding or the teeth growing too much to one side, and a discrepancy in arch integrity and crowding. Local factors such as supernumerary teeth, congenital absence of teeth, malformation of permanent successors, necrosis or dystrophic calcification of a primary tooth secondary to trauma or caries, ankylosis of primary molars may present barriers to normal eruption and alignment. The goals of treatment is to monitor the sequence and symmetry of the eruption pattern, with a basic rule that the transition should be about the same for contralateral segments. So you need to treat both sides the same, otherwise you will have malalignment of the teeth. You'll have more teeth on one side of the midline than the other. So when a permanent successor is in a normal position, the expected future development of an ankylosed deciduous molar should be a 6-month delay compared with normal shedding. Early treatment in the form of extraction of the ankylosed dentition or deciduous molar is unnecessary. So instead of phase 1 or phase 2 treatment, consider phase 0 or don't do anything. So here's a chart of eruption patterns for primary teeth, and you should see here that by the time the child is 12, all the primary teeth should have exfoliated. For eruption times for permanent teeth, by the time the child is 13, they should have all of their permanent dentition, and third molars or wisdom teeth start to erupt in the mouth between 17 years of age and 21. However, we do see them earlier now. Sometimes kids in the dental office, the wisdom teeth are erupting when they're 16 or even 15. So a word about arch length inadequacy and tooth mass redundancy, or a variety of local factors, may influence a tooth to erupt or try to erupt in an abnormal position. So remember, arch length, inefficient tooth mass, large tooth mass, or a variety of local factors may influence a tooth to erupt in an abnormal position. This condition can be so severe that a transposition of the teeth may take place. If undetected early in the mixed dentition, the child is more prone to localized factors and it may be harder to treat. So the key is to identify these eruption patterns between the age of 6 and 9. You should be taking some x-rays. If everything looks good, they don't have any decay, but you should be taking either Panorex radiograph or a full mouth set of x-rays so you can see the periapicals of the teeth in the posterior segments. Other problems include dental alveolar anterior crossbites, ectopic eruption of permanent incisors or permanent molars, posterior crossbites, open bite and flared maxillary incisors with oral habits, developmental anomalies such as ankylosis, supernumerary teeth, and missing teeth. Now a word about early loss of primary molars. Primary incisors. And this generally is due to ectopic eruption of the permanent incisors, reflecting excessive incisor liability. Individual circumstances may indicate extraction of the anteromer primary incisor to enhance incisor positioning and midline symmetry. Now, I've done quite a few of these in the past, where we do extract the primary incisor to allow the new permanent incisor to come forward and also to maintain the midline. The loss of incisors due to trauma, advanced caries, or extraction of neonatal teeth may result in anterior space loss, especially if it occurs before the primary canine stabilization is realized. So a word here about leeway space. What is leeway space? It's the amount of room or space that is created by the primary canine, first and second primary molars, and it exceeds that's occupied by the canine and premolar teeth of the secondary dentition. And this space averages about 1.7 millimeters on each side of the dental arch, and this helps alleviate some of the dental crowding. Space management through utilization of the leeway space represents one of the most critical aspects of ortho treatment in the mixed dentition. The lingual arch is the most frequently used space-maintaining device to preserve leeway in the mandibular arch. Loss of leeway space resulting from mesial migration of the first permanent molar after exfoliation of the second primary molar constitutes the most significant decrease in arch length between 4 and 17 years old. A study by Maurice demonstrated that arch perimeter decreases approximately 3.5 millimeters in boys and 4.5 in girls during the transition time from mixed dentition to permanent dentition. So that's why preserving the leeway space is so important. Most often, ectopic eruption of the permanent lateral incisors is caused by loss of the primary canines, early loss. So we'll talk about loss of the primary canines for a little bit. Unilateral loss of a lower primary canine is frequently followed by a shift in the dental midline towards the site of loss. It can cause a lingual collapse of the incisor segment and possibly deepening the bite. If there is bilateral loss of both lower primary canines, it is frequently followed by pronounced lingual inclination and distal drifting of the permanent incisors. And you may see that in some of the children that you see between the ages of 9 and 12. That's when I see it. In developing, you may see the overbite deepening with increased overjet, like more of a class 2 relationship, and a significant loss of arch perimeter is likely. So if one primary canine is lost during the eruption of the incisor, it may be desirable to extract the contralateral primary canine to maintain arch symmetry. And we've done quite a few of these in the past when one canine is lost and we remove the contralateral canine, and it does help. The recommended space maintenance for this is the lower lingual holding arch. The ectopic loss of a maxillary primary canine occurs less frequency than the mandibular loss, and is given more favorable space adjustments for incisor liability. So here you have loss of primary canines. Primarily, it's a concern in the mandible. And here you have loss of primary canines where the teeth have shifted, the midline has shifted, and there's no space for that lingually erupted incisor to come in. So what happens with ectopic eruption of permanent canines and what causes it? So the first permanent molars may be positioned too far mesially in the eruption path. There are two types of eruption processes. One is called reversible and the other irreversible. The reversible type is where the molar frees itself from the ectopic position and erupts into normal position. This is self-correcting by age 7 if it is going to be self-correcting. The irreversible type is where you see the maxillary first molar remains unerupted and in contact with the cervical root of the second primary molar. By age 7 to 8, any ectopic eruption of the first permanent molar should be considered irreversibly locked. Most of the ectopic eruptions of the first molars are seen in boys than girls. 2/3 of the ectopic molars self-correct. And here we have some examples of ectopic eruption of the upper maxillary molars, how it's going into the distal of the second primary molar. There is a less than 20% chance of familial tendency and 2 to 3% in the general public. There is a 25% ectopic eruption rate in cleft lip and palate cases. And those that remain locked, if untreated, can lead to premature loss of the second primary molar with a decrease in arch length, shifting of the upper first molar towards class 2 position, super eruption of the opposing molar with distortion of the lower curved B and potential occlusal interferences. So what we want to do for some of these treatments is to restore the second primary molar with a pulpotomy and stainless steel crown. This is designed to serve as a guide for erupting positions, but not to be taken for exaggerated molar entrapment. It's not ideal and should be avoided. But note that self-correction is unlikely approaching 7 years of age, and continued locking of the first molar with advanced resorption of the primary second molar needs intervention. Some treatment options include orthodontic elastic separators. And here you go, you can put these elastic separators between the teeth to help guide them to erupt straight. You can have separating springs that can go between the teeth, just as the elastics, but this is, you can use brass wires or just regular wires. The disadvantage of these is that they can get dislodged and the patient can swallow. And here is just a picture of the separating springs. You have appliances that can be used. A Humphrey appliance has a distal directed A-shaped loop that is actively engaged on the occlusal surface of the ectopically erupting permanent molar. Here we go, you can see it in the mouth. The Haltermann appliance is similar to the Humphrey appliance. It has a distalizing force, looks very similar to the Humphrey appliance. And again, it's in the mouth. You have that distal wire that is activated with a rubber elastic. And finally, talk about shark teeth. Permanent incisors do not exfoliate, and incisors may erupt lingual to a position, and it appears as a double row of teeth. Here you go, and what do you do about that? So you would extract the primary incisors to allow room for the permanent teeth to come forward. And usually the tongue will push those forward, but you still may have crowding. So it's up to watching the teeth develop and perhaps getting an ortho consult at the same time as to what you should do with serial extractions. And again, the growth in the lower anterior space helps to compensate for the inherent tooth mass liability. The leeway space is very helpful. you can gain 1.7 millimeters on the average on the lower arch. And here you go, you can see here that the incisor guidance has lost space. And with good orthodontic treatment and early intervention, you can have and alleviate the lower crowding from the incisors. And that completes our lecture for today. If you have any questions, please feel free to send me an email and I will answer the best I can. Thank you very much.